नमस्ते बिटिया, हमेशा खुश रहो बिटिया। I am Dr. Bharat Sharma, Assistant Professor, Department of Pathology, Faculty of Homeopathic Science, JAYOTI VIDYAPEETH, Women's University, Jaipur. Today's topic is common types of anemia. First is iron deficiency anemia. The commonest nutritional deficiency disorder present throughout the world is iron deficiency, but its prevalence is higher in the developing countries. Now, iron metabolism. The iron required for hemoglobin synthesis is derived from two primary sources. Ingestion of foods contain iron. Examples are leafy vegetables, beans, meats, liver, etc., and recycling of iron from senescent red cells. Absorption. The average Western diet contains 10 to 15 milligram of iron, out of which only 5 to 10% is normally absorbed. In pregnancy and in iron deficiency, the proportion of absorption is raised to 20 to 30%. Iron is absorbed mainly in the duodenum and proximal jejunum. The absorption is regulated by mucosal block mechanism. Absorption of non-heme iron is enhanced by factors such as ascorbic acid, vitamin C, citric acid, amino acids, sugars, gastric secretion, and hydrochloric acid of the stomach. Iron absorption is impaired by factors like medicinal antacids, milk, pancreatic secretion, phytates, phosphates, ethylene diamine tetraacetic acid, and tanninates contained in tea. Non-heme iron is released as ferrous or ferric from form but is absorbed almost exclusively as ferrous form. The mechanism of dietary heme iron absorption is not clearly understood yet, but it is through a different transport than DMT first. Transport. Iron is transported in plasma bound to a beta globulin transferrin synthesized in the liver. Transferrin bound iron is made available to the marrow, where the developing erythroid cells having transferrin receptors utilized iron for hemoglobin synthesis. Excretion. The body is unable to regulate its iron content by excretion alone. The amount of iron lost per day is 0.5 to 1 milligram, which is independent of iron intake, which this loss is nearly twice more in menstruating women. Distribution. In an adult, iron is distributed in the body as under. First is hemoglobin, present in the red cells, contains most of the body iron, 65%. Second is myoglobin, comprise a small amount of iron in the muscles, about 3.5%. Heme and non-heme enzymes, cytochromes, catalase, peroxidase. Fourth is transferrin bound iron, circulates in the plasma. Fifth is ferritin and hemosiderin are the storage form of excess iron, about 30%. They are stored in the mononuclear phagocytic cells of the spleen, liver, and bone marrow, and in the parenchymal cells of the liver. Pathogenesis. The development of iron deficiency depends upon one or more of the following factors: either increased blood loss, increased requirement, inadequate dietary intake, or increased intestinal absorption. In general, in developed countries, the mechanism of iron deficiency is usually due to chronic occult blood loss, while in the developing countries, poor intake of iron or defective absorption are responsible for iron deficiency anemia. Etiology. Based on the above-mentioned pathogenetic mechanism, following etiologic factors are involved in the development of iron deficiency anemia at the different age and sex. First, in female in reproductive periods of life, the highest incidence of the iron deficiency anemia is in women during their reproductive year of life. It may be from one or more of the following causes. First is blood loss. This is the most important cause of anemia in women during childbearing age group. Second is intake inadequate intake of iron in prevalent in women of lower economic status. Third is increased requirement during pregnancy and adolescence. The demand of the body for the iron is increased. Second is postmenopausal female. Postmenopausal uterine bleeding due to carcinoma of the uterus or bleeding from the alimentary tract such as due to carcinoma of stomach and large bowel and hiatus hernia. Adult males. Iron deficiency in male is infrequent. However, it may occur from the following causes. Gastrointestinal tract is the usual source of the bleeding, which may be due to peptic ulcer, hemorrhoids, hookworm infestation, carcinoma of stomach, and large bowel, esophageal varices, or hiatus hernia. Chronic aspirin ingestion and ulcerative colitis. Urinary tract examples are due to hematuria and globinuria. Third is nose in repeated epistaxis, in lungs in hemoptysis from various causes. Infant and in children's. Iron deficiency anemia is fairly common during infancies and childhood with a peak incidence at 1 to 2 year of age. Clinical features. As already mentioned, iron deficiency anemia is much more common in women between the age of 20 to 45 years than in men at the period of active growth in infancy, childhood, and adolescence, and it is also more frequent in premature infants. First is anemia. The onset of iron deficiency anemia is generally slow. The usual symptoms are weakness, fatigue, dyspnea on exertion, palpitation, and pallor of the skin, mucous membrane, and sclera. Second is epithelial tissue changes. Long-standing chronic iron deficiency anemia causes epithelial tissue changes in some patients. The changes occur in the nails, collincoia or spoon-shaped nails, tongue, atrophic glossitis, mouth, angular stomatitis, and esophagus. Laboratory findings. The development of anemia progresses in three stages. First, storage iron depletion occurs during which iron reserves are lost. The next stage is iron deficiency erythropoiesis, during which the erythroid iron supply is reduced. And the final stage is the development of frank iron deficiency anemia, when the red cells become microcytic and hypochromic. Blood picture and red cell incidence. These are as under hemoglobin. The essential feature is a fall in hemoglobin concentration up to variable degree. Red cells. The red cells in the blood film are hypochromic and microcytic, and there is anisocytosis and poikilocytosis. Reticulocyte counts. The reticulocyte count is normal or reduced. Absolute value. The red cell indices reveals a diminished MCV below 50 FL or diminished MCH below 50 Bg and diminished MCHC below 20 gram per deciliter. Fifth, leukocytes. The total and differential white cell counts are usually normal. Platelets count is usually normal. Bone marrow finding. Bone marrow examination is not essential in such cases routinely, but is done in complicated cases so as to distinguish from other hypochromic anemias. First is mature cellularity. The marrow cellularity is increased due to erythroid hyperplasia. Erythropoiesis. There is normoblastic erythropoiesis which predominates of small polychromatic normoblast. The cytoplasmic maturation lags behind so that the late normoblast have pycnotic nucleus but persisting polychromatic cytoplasm. Other cells, myeloid lymphoid and megakaryocyte cells are normal in number and morphology. Marrow iron. Iron staining Persian blue reaction on bone marrow aspirates smear shows deficient reticuloendothelial iron stores. Biochemical findings. These are as under. The serum iron level is low, normally 40 to 140 μg per deciliter. It is often under 50 μg per deciliter. Total iron binding capacity is high and rises to give less than 10% saturation. And serum ferritin is very low, normal 30 to 250 nanogram per milliliter, indicating poor tissue iron stores. Principle of treatment. The management of iron deficiency anemia consists of two essential principles: correction of disorder causing the anemia and the correction of iron deficiency. This session is powered by Digital Version 2.0, Jyoti Vidyapeeth Women's University. I hope you all enjoyed this session. If you have any query, please mention it in comment box. Thank you.